sir. Yes, sir.
Is it possible?
Sir, please can you repeat me 1 second? I was just into the live.
Okay. Now I am saying after I make my presentation, I
Mm,
have a couple of questions which I have put on the slides. So
okay.
yeah. So we will ask the audience to answer the questions. So the answers they can put it on the chat box, right?
Yes, sir. I'll request our technical team to open the chat box for everyone. Okay. So they
Yes.
can
So
put the
once
answers in the chat box.
yes, and we
One
can
minute, sir. Let
see how many correct answers we have got, right?
Yes, sir. We can see that as well. Just give me 2 minutes.
Yeah.
Uh, Hello, sir.
Yeah.
Yes, the chat box is open for everybody. So everyone who is answering the questions will be in the chat box and we'll be making a note of so that we can come to know who answered the first.
Okay. So the question answer sessions will be at the end, right?
Yes, sir. Yes, sir. Of course.
So once they have the questions, they will be unmuted or something like that,
Uh,
or they have to just type the questions.
they have to type their questions in the chat box. I mean, they have to
Okay.
type their answers in the chat box.
Okay. So even if it's a question they have to ask, they have to type it in the chat box, and the team will collect those questions and
Yes,
we will answer them in the end. And also the
yes,
answers whichever are there to my questions, they will also be answered in the chat box, right?
yes, sir. Exactly.
Okay, fine. All right. So how many people are there? So 33 participants are there. We'll wait for some more time.
Yes, sir. We can wait for 5 more minutes so that participants can join. I'll give any
Okay.
reminders to everybody to join us.
Yeah. Shravani, I think we should start now. Already there are a lot of people. Okay,
Sir?
we should start now.
Yes, sir. 2 minutes, sir. I'll be starting.
Yeah, I have to share my screen, right?
Yes, sir. Yes, sir. 2 minutes. Good evening, sir, and good evening, everybody. I welcome you all to the webinar on New Paradigm in the Management of the mCRC organized by International Association of Oncology. About IAO, International Association of Oncology is the one of the renowned professional association meant for research and development in the field of oncology. IAO is an international forum for which researchers, academicians, doctors, and practitioners for sharing knowledge and innovations in the field of health science and life science. IAO aims to bring together worldwide researchers and professionals and encourage intellectual development and provide opportunity for network sharing and collaborations. On behalf of International Association of Oncology, I would like to extend a warm welcome to our esteemed speaker and the participants who have joined this forum. I can assure you that this session would be highly informative to all the participants here. This session is sponsored by Dr. Reddy's Laboratory. Uh, it's given me immense pleasure to introduce the speaker for the day, Dr. Shaurabh Kumar Mishra, sir, Associate Professor, Department of Medical Oncology and Hematology, AIMS Bhubaneswar, India. Over to you, sir.
So thank you, Shravani, and thank you, IAO and TRL and Jai Shri Ram. So I would like to share my screen. So is my screen visible? Is my screen visible to everyone?
Yes, sir. I can. We can see your screen.
Fine. So let us start then.
Yes, sir.
So, dear audience, I am a medical oncologist based out of All India Institute of Medical Sciences, Bhubaneswar. We started the Department of Medical Oncology here, and colorectal cancers and GI malignancies are some of the malignancies which we are working upon and on which we are very much interested. We see a lot of cases of colorectal cancer and gastric cancer in this part of India. What I am going to discuss today is the paradigm in the management of metastatic colorectal cancer. So let us first start with the basics. The audience comprises of clinicians, MBBS, postgraduates, and other doctors and allied specialties. So colorectal cancers, the risk factors can be hereditary risk factors. So basically, if there is a family member who has a deleterious gene and suppose he has a cancer also, so now these deleterious genes can be transmitted through the germ line, and that can lead to hereditary colorectal cancer. So there are multiple members in the same family who have cancers. So they have a positive family history. It is one of the risk factors for colorectal cancer. Now, aspirin use is it decreases the risk of colorectal cancer. Ethnicity, male gender, type 2 diabetes, inflammatory bowel diseases, they increase the risk of colorectal cancers. Now, there are certain modifiable risk factors. Now, heredity, this is non-modifiable. You cannot modify your family history, but there are certain risk factors which can be modified. So that means that these risk factors um, can very well be modified to prevent this cancer. So smoking, processed meat, red meat, beef, pork, these are red meat. Alcohol intake, low intake of vegetables and fruits, which are rich in fibers, fatty body fat and obesity. All of these are increased risk factors. So you can modify them. And modifiable risk factors which decrease risk. So just opposite of that. If you have a physical activity, your body fat is low, then therefore the obesity comes down. If you're taking a diet which is rich in fibers, whole grains, dairy products, fish, tree nuts, vitamins, D, C, calcium supplements, all these things are risk factors which decrease the risk. I mean, they are modifiable risk factors. That means they reduce the risk of colorectal cancer. Having known this, we next come to the pathogenesis of these cancers. So as you can see, so can we just reduce this panel, or it has to be there? I mean, this panel which is there, can it be just reduced or no?
Sir, there is an this was into your screen, sir. This part.
It's in my screen only. I don't know how
Then
to
you
reduce.
zoom
Okay,
in
then
and
I'll just leave it wherever it was. Fine, fine.
okay, sir.
Yeah. So basically, if you see, there are three pathways of colorectal cancer. Why the colorectal cancers develop, that we saw the risk factors, but how do they develop? So there are three pathways here. One is the adenoma carcinoma pathway. That means there is a colorectal adenoma, precancerous lesion. Subsequently, by acquiring certain mutations, that may be either germline mutation of the adenomatous polyposis coli at APC mutations, or the sporadic APC mutations. Sporadic means which just happens by chance. That means there is no family history, no risk. I mean, there is no hereditary risk, and that is known as sporadic. And in which, in the adenoma, if there is a mutation in the APC adenomatous polyposis coli, or if there is a germline mutation in the syndromes known as the familial adenomatosis polyposis, these will be the initial driver mutations, and then subsequently they will acquire certain more mutations, like the mutations in the KRAS, BRAF, SMAD4, TP53. When this sequence of mutation happens, an adenoma becomes a carcinoma. Now these are microsatellite stable colorectal cancers. What are microsatellites? We will discuss a bit later. Now, this is majority of the colorectal cancers will have or will develop in this pathway, via this pathway. Now, there is another pathway, serrated neoplasia pathway, in which there are certain polyps, serrated polyps like adenomas, like there are precancerous polyps. And now these polyps, they also acquire certain mutations in the KRAS and BRAF, and then subsequently other mutations like MGMT, MLH1, CIMP, and finally they also become either a macrosatellite stable or an unstable colorectal cancer. This is another pathway other than the adenocarcinoma. And still lesser in incidence is the microsatellite unstable pathway, which occurs around in 2 to 7% of the patient. So what is a microsatellite? Basically, for that, you should know something about the genetics, the repair of DNA damage. So if the DNA is damaged during the replication, then there has to be repair of this DNA. If you don't repair the DNA, then the cell division will completely go haywire and the cell will die. So DNA replication has to be maintained by repair of the DNA. So during division, if the DNA gets damaged, then there are certain proteins known as the mismatch repair proteins, or MMRs, right? So if these mismatch repair proteins, if there is a, DNA is double stranded. So if there is a break in one strand of DNA, the single stranded DNA break, then the mismatch repair proteins, they repair this break, and because they repair this break, the cell cycle just continues. Now, what happens if the mismatch repair proteins are deficient? Now, if the mismatch repair proteins are deficient, so automatically the DNA replication will also go haywire. So, a lot of segments of repetitive fragments of nucleotide repetitions will be there. So, let us say around 50 to 100 nucleotide repeats. You know, nucleotides are the building blocks of the DNA. So, there will be defective nucleotides which will keep on repeating. They will go on happening and happening and happening, and these repeat sequences of nucleotides are known as microsatellites. And when therefore there is a deficiency of a mismatch repair protein, lot of microsatellites will be formed which can be detected by a test, and the condition is known as microsatellite instability. So microsatellite instability just means that there is a deficiency of the mismatch repair proteins, leading to buildup of lot of microsatellite fragments, and this is condition is known as microsatellite instability or MSI high. MSI, microsatellite instability, is high. Now suppose the MMR proteins are intact, mismatch repair proteins are intact. Now that is something in which you can see here the adenoma carcinoma pathway in which the mismatch repair proteins are intact, and as a result these are microsatellite stable colorectal cancer. That is the difference. So what happens in this 2 to 7% of the patients when there is germline mutation in the mismatch repair genes? This condition is known as Lynch syndrome, and in this Lynch syndrome there is deficiency of these mismatch repair proteins like MSH26, MLH13, PMS26. And this leads to microsatellite instable colorectal cancer. What is the clinical significance of this? Now, microsatellite instable colorectal cancers are exquisitely sensitive to immunotherapy. So that is what we will see subsequently, right? So now let us discuss something about, we have learned about the risk factors. We learned about the genetic pathways which are involved in colorectal cancer. Now discuss something about how these colorectal cancers develop. These mutations we talked about, right? The RAS mutations, the BRAF mutation. What happens? Why do the cancers develop when there is a mutation in these pathways? So here you just see this. This is a typical tyrosine kinase EGFR epidermal growth factor receptor. This is the receptor which is expressed on all the cells. Let us cell in the colorectal cell, it is expressed. Now what is the ligand for this receptor? So any of the growth factors, they can be a ligand. Fibroblast growth factor, epidermal growth factor, platelet derived growth factor, all of these growth factors, they can bind to this receptor. And when they do bind to this receptor, what happens then what happens is that there is a downstream signaling. So this RAS, it is there, the BRAF, another protein is there, MEC12, another protein is there, ERK12, all of these are component of the MAPK pathway, MAP kinase pathway, tyrosine kinase. So in this MAP kinase, once the ligand binds to the receptor, there is downstream signaling. So when there is downstream signaling, ultimately what happens? Because of the presence of growth factor and interaction with the receptor, the cell now starts to divide. The cell starts growing. The cell survives. So that is the mechanism in a normal cell. What happens if this receptor is mutated? Suppose RAS is mutated or BRAF is mutated. So what happens now? The pathway becomes independent of the ligand. That means even if there is no growth factor, the cell constitutively keeps on dividing, ultimately becoming a cancer. That is the mechanism. So they have become addicted to this mutation. They do not require any ligand. They do not require any interaction between growth factor and the receptor, and the cell becomes autonomous and starts dividing again and again and again and becomes a cancer. So the Achilles heel is here, the mutation in the RAS or RAF. So if you can just block these things, these mutations, or you can block the interaction between the growth factor and ligand, then there is one more, there can be, you can arrest the cancer. So how can it happen? Now let us see two situations. Now, one situation in which a colorectal cancer in which the RAS is not mutated. So there can be cancers in which RAS is not mutated. There can be cancers in which RAS is mutated. Not all colorectal cancers will have RAS mutation. Many of the colorectal cancers won't have a RAS mutation. So they are known as wild type RAS. That means one is mutated RAS, in which the RAS gene is mutated, and there can be a wild type RAS when the RAS is unmutated. Now, suppose in a colorectal cancer, the RAS is unmutated. That means the cell is very much dependent on the downstream pathway. That means is intact. That means the receptor is binding to the ligand is binding to the receptor, and then it canonically goes through all these pathways to cause cell survival. So binding of the ligand to the receptor, it happens if and for the cell survival. So if you could just block this interaction between the growth factor and the receptor, then by a monoclonal antibody known as cetuximab, then automatically the cancer arrest happens. Therefore, the clinical significance of this is that in a patient who has colorectal cancer in which the RAS is unmutated, then in such or wild type, in that situation, the cetuximab is a very useful drug in the management of such cancers. However, if the RAS is mutated already, what would happen even if we block the signal? There is nothing which is going to happen because already this is mutated and downstream signalings are happening. So even if you block the interaction between a ligand and the growth factor and the receptor, there is no effect on the cancer. Meaning to say, cetuximab is not useful anti-EGFR monoclonal antibody. It is not useful in RAS, BRAF mutated colorectal cancers. It is only useful in a RAS or BRAF unmutated or wild type cancer. So we got certain paradigm of clinical significance. Next, we come to this very, very important fact, which has probably, I mean, found to be of clinical relevance very recently. I mean, last 4 or 5 years only we are talking about. Previously, we are talking about irrespective of sidedness. We were talking about right-sided, left-sided. We never spoke. All colon was taken as the same thing and therefore treated in the cancer arising. Any part of the colon was treated in the same manner. But now there is a difference. There is a difference in the right-sided colon, which extends from the cecum till the hepatic flexor and I mean the splenic flexor, and then there is a left-sided colon which comprises of the descending colon, the sigmoid colon, the rectosigmoid, and the rectum. These are the left-sided colon. So as you can very well see, the right-sided colon, which comprises of the transverse colon and ascending colon, it is a midgut derivative. Mostly these cancers are seen in women with sessile, which arise from sessile serrated lesions. That is the part 2 which we had seen. Most of these are mucinous tumors. Overall, these tumors have a worse prognosis compared to the left-sided tumors. They have a high CIMP, high BRAF mutation. They are MSI high. They are MSI immune tumors. The metabolic tumors, these are the classification of molecular classification of colorectal cancers. They have more expression of KRAS, they are more having KRAS mutation. And the left-sided colon, which is usually hindgut derivative, more seen in men, the colorectal cancers, overall they have a better prognosis. They have a CMS4 or CMS2 subtype of colorectal cancer, and they are more TP53 mutations are more common APC mutation, but prognostically, the left-sided colons are doing better compared to right-sided colons. So now there is a difference in the treatment of the left-sided and the right side. You don't treat them in the same manner. So we learn two aspects here. One is that we treat the tumor based on the mutation type, whether it is EGFR, I mean the RAS is mutated or RAF mutated, that thing we have to consider, because if RAS or RAF is mutated, you cannot give anti-EGFR. Second thing, we see whether the tumor is right-sided or left-sided. That also helps us in our treatment decisions, right? So with this background, we now find that the treatment has evolved from purely chemotherapy on the left hand side, when the survival would be in a metastatic cancer would be around 15 months, to now we are already reaching around 39 months, with combination of the chemotherapy with biologics, especially the knowledge of the molecular pathway of cancer colorectal, personalized therapy, and with left-sided tumors, we can now having a median survival of beyond 3 years. So here it was only 1 year. So over a couple of decades, with the knowledge of the molecular biology and with the identification of the sided role of sidedness, we now see that appropriately personalized therapy can lead to very significant improvement in the outcomes of the colorectal cancers. Patients can survive beyond 3 years. So it is important to understand that the first line treatment is the best treatment. So putting your best foot forward. Why? We have seen in our clinics, in the first line, the responses to treatment will be 38 to 69%. Median progression-free survival will be around 1 year. 100% of the patients will receive first line therapy. However, when you reach the second line, 55% of the patients are already dead. So if you don't give the best treatment forward upfront and you just wait, okay, when the patient progresses, I will go for the next treatment and my best treatment, yeah, probably 55% or half of the patients will miss that bus. Okay. And when you come to the third line, still less, only 2 to 4 months. So it is always prudent in colorectal cancer that we go for the best treatment upfront. What are what are the parameters which we take at the baseline or consider at the baseline for treatment of colorectal patients? So one thing I said, patient characteristics. So comorbidity, elderly patient, poor general condition, whatever it is, you cannot go for an aggressive treatment. You have to go for a mellowed down approach. Now, suppose someone has received a prior adjuvant treatment and very rapidly someone progresses. So you cannot just give whatever adjuvant he has got. You may have to change the treatment in the subsequent line. Example is that suppose colorectal cancer, you have given capox chemotherapy adjuvant, and now after 1 month of completion of chemotherapy, the patient recurs. So you cannot re-challenge with capox, capecitabine and oxaliplatin. You have to go for capecitabine or irinotecan. However, if the patient has relapsed after, let us say, 4 years of last adjuvant therapy and he doesn't have any more neuropathy and all, you can re-challenge with capox. Age, as far as our clinical practice is concerned, even if it's 80 years old and he's very fit, we would like to give him the best treatment. Age is a very important factor because there are a lot of comorbidities, but the performance status, as we can see here on the right hand side, we can see if someone is in 80 years and a very well preserved performance status, probably we'll have to go for the appropriate aggressive treatment rather than just saying no, he's elderly, we would not give. So these are clinical decisions to be made. So with age, you have to go for something known as the geriatric index. That means you have to assess them on multi-parameter geriatric questionnaire to find out how fit is he for chemotherapy. Now you come to tumor characteristic, tumor burden. Now someone has a very high tumor burden. What are you going to do? When you are having a very high tumor burden, you would like to go for some therapy which brings about a rapid response. Resectability. Suppose a cancer, a metastatic colorectal cancer, it has limited metastasis, 1 or 2 metastases in the liver. So you can very well take down a metastasis and you take out the metastasis, and very well you can take out the primary. So it is a resectable still. However, if suppose there is a colorectal cancer with extensive metastasis in the liver, lungs, bones, then in such a situation, it becomes unresectable and goes only for systemic therapy. Tumor location, as I said, left-sided tumors have a better prognosis compared to right side. We come to molecular characteristics. Very well, I have said RAS, BRAF mutated tumors are unresponsive to anti-EGFR therapy. MSI high tumors are very prone and to respond to immunotherapy. HER2 mutated cancers can be considered for targeted therapy with trastuzumab deruxtecan, which is an antibody drug conjugate. Patient preference. Now, suppose someone is a fit patient, doesn't want to be go for very aggressive therapy. So we may have to mellow down the approach to him. Toxicity profile. Already a patient is diabetic, severe neuropathy at baseline. He is unable to write, he is unable to button his shirt, and he is unable to put on his shoes. I mean, such patients you'd like to avoid oxaliplatin. Meaning to say, when we consider the treatment of a patient with colorectal cancer, we have to consider this whole gamut of the parameters before we proceed for treatment. So, and very elegantly here has been displayed that when you, as you go down first line, second line, third line, fourth line, you can see 100% of the patients will receive for first line, but only 20%, 30% will receive the fourth line of treatment. So there are multiple drugs, chemotherapy, other than chemotherapy, which have now found their way into the management of colorectal cancer. Previously, we used to give only chemotherapy. Now we have biologicals known as anti-EGFR, epidermal growth factor receptor monoclonal antibodies, and anti-VEGF, that is anti-vascular endothelial growth factor antibodies. These are the two biologics which are routinely used in the management of metastatic colorectal cancer other than chemotherapy. A newest form of treatment is immunotherapy. So strong biological rationale and meta-analysis results support that selection of anti-EGFR prior to anti-VEGF therapy. Now, there was some data to show that anti-EGFR combined with chemotherapy, anti-VEGF combined with chemotherapy in frontline setting leads to similar survival outcomes. So therefore, how do you choose whether anti-EGFR to be given or anti-VEGF to be given? One of them is the mutation status. But then subsequent meta-analysis have shown that if you use anti-EGFR prior to anti-VEGF, then you are probably going to do better and good for the patient. Anti-EGFR therapy, it promotes the rapid debulking. So if suppose there is a where you need a rapid response and depth of response, you should use anti-EGFR. It lowers the potential for resistance as fewer tumor cells remain. So this is the sensitive clone, this is the resistant clone. So it lowers resistance and it primes the molecular circuitry towards VEGF dependency. Meaning if you go for first line cetuximab, then it primes the tumor for subsequent benefit with anti-VEGF agents, right? So first line probably anti-EGFR therapy is commonly to be used. There is another thing to say here that suppose you are using a first line in cetuximab. So what will happen anti-EGFR is that initially at baseline, there are many cetuximab sensitive clones and therefore they will respond. But subsequently, when there is disease progression, this will be because there are a lot of now cetuximab resistant clones which have come up. So now what will happen is second line, you don't go for any cetuximab. You just go for either anti-VEGF therapy. Now, without cetuximab, there will be a selection. What selection? Now, without cetuximab, the cetuximab sensitive clones will re-emerge. So, without cetuximab selection pressure, the cetuximab cell lines, sensitive cell lines will re-emerge so that subsequently you can re-challenge with cetuximab. So this is again known as the Santini hypothesis. First line anti-EGFR, second line VEGF, no EGFR, anti-EGFR, so that third line re-challenge with anti-EGFR. This is a very, very sound hypothesis. We do this in our clinical practice as well. Now, with all of these things, we now come to some real-world clinical trials data, which I would like to present. So this is what we have known, anti-EGFR addition, anti-VEGF addition to chemotherapy improves overall survival of patients with unresectable metastatic colorectal cancer. Now survival has gone beyond 30 months. And in comparative trials, some studies have shown, like the SWOG-CalGB study, which has shown that overall survival was similar for cetuximab and bevacizumab when combined with chemotherapy in the front line. So there is not much to choose between the biologics. But there was a subsequent study which showed that cetuximab or anti-EGFR improved overall survival versus VEGF or anti-VEGF bevacizumab in the front line. So there is ambiguity and we need more data. In this context, the benefit of anti-EGFR antibody may be enriched in, as I told you, in RAS wild type patients with primary tumor originating in the left side of colon and rectum. This is also we've discussed. We have seen that more right-sided tumors are RAS mutated. The left-sided tumors are enriched are enriched with RAS wild type. Therefore, anti-EGFR molecules are very much useful in wild-type tumors with RAS in the left side colon. And therefore, a study was designed to test the superiority of panitumumab, which is another anti-EGFR monoclonal antibody, versus anti-VEGF bevacizumab plus standard chemotherapy in RAS wild type and left-sided metastatic colorectal cancer. So what happened? 823 patients randomized to panitumumab plus FOLFOX6 versus bevacizumab, and with a primary endpoint of hierarchical analysis for left-sided colon if the outcome is significant to go for overall population. This is the study schema, and these are the statistical consideration. So we can see here that the analysis shows here, these are known as Kaplan-Meier survival curves. On the lower panel x-axis, we have the number at risk and the years from the time to start. So 0, this is where the study starts, and 84 months till that they have followed up. And the y-axis is the survival in percentage. So you can see the Kaplan-Meier survival curve. The green color one is that of the anti-VEGF, and the blue color one is that of the anti-EGFR. So on left side colorectal cancer, you can see the left one performs better compared to right sided. So in the modified, I mean in the panitumumab FOLFOX arm, there was a statistical significant improvement in overall survival compared to bevacizumab. So this is the primary analysis which they wanted. So this is a positive study. So in left-sided population, if it is wild-type RAS, you should use anti-EGFR because that leads to improvement in overall survival. Now coming to that of the second in overall survival in overall population, that means left-sided as well as right-sided. Now here also you can see there is a statistical significance. So this study shows that anti-EGFR compared to anti-VEGF in first line wild type colorectal cancer, irrespective of wherever the disease is, the right sided or left sided, based on the intention to treat population, is probably better than anti-VEGF. Now there is a twist here. We cannot just generalize this data to everything. Preferably this data is meant for the left-sided tumors. As you can see here, you can very well see in the overall population, the primary tumor location, if it is a left-sided tumor, the benefit you can see 0.83. This is one. So if panitumumab is better if the triangle, if it is on the left hand side. So definitely in left sided tumor, the magnitude of benefit is very good. Now just see in the right sided tumor, it very much has a trend towards showing bevacizumab better. So what do you mean? It means that the benefit of anti-EGFR monoclonal antibodies is predominantly determined by the response and outcome on the left sided. Probably in the right sided tumors, they do not have much benefit, even if these are wild type RAS tumors, right? This is what, so therefore the right sided tumors are not doing very good. Now, progression-free survival was very similar, nothing to do with that, and some responses, toxicities. So what does this study conclude? This study concludes that this study shows that the study met its primary endpoint, demonstrating the superiority of first-line panitumumab versus bevacizumab. So anti-EGFR is better than anti-VEGF when combined with chemotherapy in left-sided colorectal cancer rather than in the right-sided. This is what on the subgroup analysis and outcome of the study shows. PFS was very similar and there was no new safety signals. So toxicities were as usual. So this supports the role of anti-EGFR plus chemotherapy as first-line treatments for patients with RAS wild type and left-sided. So I think this is the exact statement which I am also making. We cannot say that if it is a right-sided tumor, if it is wild type RAS, we should go for anti-EGFR. Probably no, because that doesn't work in that setting. So after discussion of the anti-EGFR and biologics, just few slides on microsatellite instability high tumors, MSI high. I told you now, if there is a deficiency of mismatch repair proteins, these tumors become microsatellite instability high, and these tumors are exquisitely sensitive to immunotherapy. Immunotherapy means anti-PD-1, anti-PD-L1 monoclonal antibodies. That is altogether a different session, I would say. I'll just highlight you in a very recent study, just a couple of days back, this study came. What I want to show you is the impact of immunotherapy in MSI high tumors. Just try to understand this. Now, all of these patients were having MSI high tumors, right? Colorectal cancer. And now they were randomized into two arms. One of them is that standard which we go for all patients, like I said, chemotherapy with anti-VEGF or anti-EGFR. And another arm was in which they combined them with variety of immunotherapies that is known as nivolumab plus ipilimumab, anti-CTLA4 monoclonal antibody, anti-PD-L1 monoclonal antibody. They combine them and they want to find out these two comparison of the arms, what would be. So this is what. Now on the background, I would like to tell you there is already a positive study showing that pembrolizumab, which is a immunotherapy against PD-1, so anti-PD-1 monoclonal antibody, it leads to very significant improvement in overall survival in patients who are having MSI high compared to the same chemotherapy and anti-VEGF. So there is already a background showing that there is good improvement in outcome. So this is a different immunotherapy molecule they have used. Just see the Kaplan-Meier curves. Can you just see here? I had shown you one Kaplan-Meier curve here. As you can see, very, very different. Now this orange color one is the one which shows the immunotherapy. So almost all the patients, they are surviving. And here, as you see here, there's a very steep drop in patients. So patients are not surviving anymore. So here, this is exactly what the microsatellite tumors, high tumors undergo when you give immunotherapy, and see the very significant hazards ratio. Now, this is a beautiful curve, but we need to see the overall survival. Suffice it to say that when you have a MSI high tumor, which is a very small fraction of tumors, as I showed you, 2 to 7% of the tumors, you must consider immunotherapy, either pembrolizumab or nivolumab plus ipilimumab. We are eagerly awaiting for the overall survival data for these patients. With all this knowledge, now let us come to how are we going to treat our patients. So when we have a stage 4 unresectable metastatic colorectal cancer, first line therapy, we discuss about comorbidities, metastatic disease, and it is unresectable, lot of comorbidities, just go for a single agent, either fluoropyrimidine with bevacizumab. If it's a frail and elderly patient, you can go for again same fluoropyrimidine plus bevacizumab, easily tolerated. If it is a rash wild type, you can go for chemotherapy with anti-EGFR, or you can just go for anti-EGFR alone. Now, if the RAS is wild type and the BRAF is wild type and the patient is a very fit patient, and if it's a left side colon cancer, then we go for the chemotherapy doublet and anti-EGFR. That is what I have already told you, that in RAS mutated and left-sided colon, the RAS and BRAF wild type and left-sided colon, the best regimen is a chemotherapy doublet with anti-EGFR. However, what happens if RAS wild type and BRAF wild type, but it's a right-sided? Very clearly, I showed you in that forest plot that anti-EGFR doesn't work, even if it's a wild type tumor in the right side. So the preferred is chemotherapy doublet with bevacizumab or anti-VEGF, or the chemotherapy triplet with bevacizumab. However, if you need a rapid tumor shrinkage, as I told you, not the survival, if you need a very rapid tumor shrinkage, I had shown you that anti-EGFR molecules can go for very rapid tumor shrinkage. Okay, just give me 1 second. So that therefore preferred is this. Now, if there is a RAS mutated, then you cannot give anti-EGFR anyways, whether it's a left-sided or right-sided. You have to go for chemotherapy doublet on bevacizumab or chemotherapy triplet with bevacizumab. Okay, and now BRAF mutated, you have to go for some of these options. And if it's a MSI high or deficient MMR, then we go for pembrolizumab. And now we have an additional option with nivolumab plus ipilimumab. I think we can pretty well understand how we have decided this therapy. Now, having come to the end of this, now I would like all of you to just answer this question. So you can type your answer, whichever is the correct option. Which molecular marker is not useful in deciding therapy in metastatic colorectal cancer? So at the baseline, you need to do certain mutations. So it is whether RAS mutation or BRAF mutation or MSI status or TP53 mutation. Let us see the answers. All of you, please try to answer the question so that we know that you are able to, you have grasped the things. I'm seeing very correct. Everyone has, I think, very well answered the question. None of them have answered a wrong question. I can see all of them. That means that you have actually understood the topic pretty well. So very correct, very, very correct. I'm happy that you have, all of you are exactly answering the right answer. So as I very well told you, RAS mutated, you cannot give anti-EGFR. You need to do RAS mutation. It is useful in deciding therapy. BRAF mutated, you cannot give anti-EGFR downstream pathway. So you need to, this is a useful markers. C, someone has written, I think C is not the right answer, Avinash, because as I told you, MSI status, we need to know. Why MSI status? That also I told you, because if it is MSI high, we have to consider immunotherapy. So it is a useful marker. TP53 mutation doesn't have to do anything. So TP53 is the most common mutated gene in the cancers, and usually TP53 mutation doesn't have any clinical relevance as far as therapy is there. Very good, all of you. Now the last question is, which therapy is not appropriate for RAS mutated metastatic colorectal cancer? I mean to ask you that if the RAS is mutated, which therapy is not useful? Not useful. That's what I'm asking you. If the RAS is mutated, which therapy is not useful? So there is a discrepancy in the answers. Some of them are trying to answer the right answer. So some of them have answered the right. I think most of them are answering the right answer. Most of them are answering correctly. Couple of them have not been able to answer the correct, but otherwise most of them are doing good. Very good. So as very clearly told, anti-EGFR therapy. So let us explain to you once more. I think there is some question why anti-EGFR cannot be given. So you see here, so RAS is a downstream pathway of EGFR. If RAS is mutated, that means it is mutated downstream. What happens if you block the antibody and I mean the binding? Nothing happens. Anyways, the tumor is going to continue dividing because the block is upstream, the mutation is downstream. Only if this is an unmutated or the RAS is wild type, that means it is not mutated, BRAF is not mutated, then only if you block the ligand and receptor interaction, automatically the cell will stop dividing and automatically the cancer will die. So this is the reason. Now coming to why does it not work? Uh, 1 minute. So why does the tumor, I mean, so in the right-sided tumor, if the wild type RAS is there, still why does anti-EGFR not do that good? We do not know the answer to that. We do not know the answer. It is simply that theoretically we say that yes, anti-EGFR should work irrespective of whichever side. Now, that was when in the era when we did not understand the significance of the left-sided and right-sided, the dichotomy, the difference in the outcomes. Now we know that anti-EGFR work best if it is a left-sided wild-type tumor. Now, why does the wild-type tumor on the right side anti-EGFR not work? There are a lot of other theories. As I said, these are molecularly different tumors compared to left-sided. There is some data to show about the microbiome, that means the gut bacteria, which can cause the treatment difference in the treatment outcomes. So all these things, all these theories are there. So I think I have completed this topic with these questions and answers. I'm very happy. Most of you have answered it very well. So Jai Sri Ram, and if there are any more questions, the panelists, I mean the technical team can help me with that. Thank you.
Thank you, sir.
Thanks, Ravni. So are there any questions or we can just complete the session? So I think there are two questions here. Can you repeat which sided cancer is treated? So as I said, left-sided RAS and BRAF wild type is treated with anti-EGFR therapy. At which age the chances of cancer increases? So colorectal cancer, so beyond 40 years, 50 years, we should be going for screening by either the fecal occult blood testing or annual colonoscopy. All this can be done at around 40 to 50 years. If there is a strong family history, we have to go for screening earlier. So I think that's that many questions are there. So Shravani, I think we can stop it. So over to you.
Yes, sir. Thank you, sir. Thank you, sir. This session was indeed very insightful and interesting. Um, by this, we have reached to the end of this webinar. So once again, I would like to thank Dr. Shaurav Kumar Mishra, sir, for joining us as a speaker, and Dr. Reddy Laboratory for sponsoring this session, and our each one of you and your active participation and involvement in the webinar. The details about the certificate and feedback link of this webinar will be shared to your registered email IDs via mail this week. Once again, I'll be repeating. For each and every registered participant, the details about the certificate and feedback link of the webinar will be shared to your registered email IDs by this week. Once again, I thank you all and good night. Thank you, sir.
Good night.
Thank you very much.
Thanks.
Thank you, sir.